Hello, everybody. Yeah, that'd be great. Thank you so much for coming, our wonderful audience. I'm Dr. Alexandra Mannix.
I'm Dr. Melissa Parsons, and we're from the University of Florida, Jacksonville.
Today we're going to be talking to you about gender in medical education and the things that we should know as educators.
Yeah, so we're going to go through kind of this list of goals and objectives. And one thing that we have a very small group, so one thing that we want to offer is if you feel uncomfortable asking a question out loud, you can scan this QR code and you can type questions into a Google Doc, and then we will look at them at the end. I'm actually going to scan it also so I can use it for us to go over it as we go. But it just gives a safe way to ask questions that you may not want to ask in a large group setting.
And honestly, I'm throwing a curveball. With the size of this group, if you have questions while we're in the middle of anything, please feel free to ask.
So first, we're going to do a little bit of terminology. So there's a lot of terms, gender-based bias, gender-based discrimination, that we can use. And so we're going to stay with gender-based discrimination today, or you're going to hear us use the acronym GBD to talk about gender bias, sexism, discrimination, things that we may experience in our training environment. And while I understand that the word discrimination in and of itself has a lot of negative connotations, we want to be clear that this doesn't necessarily mean it's something that someone is purposefully doing, right? But can be just that an undertone, undercurrent type of thing. Something like, oh, she just had a baby, she probably doesn't want XYZ opportunity, etc.
In addition to that, we kind of wanted to touch on gender versus sex. And we know in the literature, the recommendation is to use the words men and women when you're talking about gender, and more male and female when you're talking about biology or sex. And what we want to really throw out there is we may use these interchangeably today. Sometimes when you're speaking, we might interchange these words simply because they sound better in that sentence or feel better coming out of our mouths, but we wanted to establish that there is a difference, and we do recognize that.
So in terms of examples of some gender-based discrimination that you may see, right? Different standards of evaluation, being denied opportunities, being mistaken for a non-physician, which probably all of us in the room have experienced, being advised against having children during residency, feeling like pregnancy or childcare leads to negative reactions, et cetera, are kind of all things that we would encompass under gender-based discrimination. So the first thing we really want to look at today is gender's impact on the experience of our trainees, right? And that can include medical students, residents, fellows, et cetera. And I think that kind of in the classroom, we really start in an environment that we feel is pretty equally footed, right? Like I can raise my hand in a classroom, answer a question, get all A's, and be equal to my male counterparts. And really where we start to see gender-based discrimination standing out is as our medical students transition into the wards for the first time. It's kind of that first moment. And so our first study that we're going to talk to you about today is this one, the effect of gender on clinical clerkship experiences. So this looked at medical students' first clerkship, and it could be anything ranging surgery, peds, et cetera. And what they found was that female medical students really struggled to define their role on the wards. And so not knowing what that role should be, they defaulted to these stereotypically feminine roles, right? Of taking care of patients in terms of like cleaning things, getting things for patients, nurturing, helping the nurses, or saying, I don't know a lot. And that was different from their male colleagues. There were also perceived differences in their workplace relationships where they found that they were making relationships more with nursing staff and patient staff, and their male colleagues were making these kind of hierarchical relationships with supervising residents, physicians, et cetera, attendings. And they also found gendered expectations shaped their interactions with other people. So the med students accepted that they had expectations of their supervisors. I think one of my favorite ones was talking about a female pediatrician who they expected to be kind of warm and fuzzy, and when she wasn't, they negatively viewed her, right? They felt unable to negotiate uncomfortable situations, specifically with supervisors that they worked with, like their attending physician, et cetera. And they encountered a gendered learning curve. And this is a really important concept. So what they meant by that was like the males around them, male attendings, residents, had this air that they deserved to be a physician, that they were respected in that way, that was something that was just accepted. Whereas the females were constantly struggling to prove that they fit, right? And our trainees are having to walk kind of this tightrope of how do I prove that I fit? How do I prove I'm good enough for this role? And so one quote that came from this study, I didn't take as much initiative as I thought I would. And to me, it was clear that I was doing it because I felt like I didn't fit in, right? And so as educators, we need to recognize these moments for our learners where they may not feel that they belong. They may not feel like they fit. And we need to encourage them and empower them to improve their education. So this is one of my all-time favorite studies, strictly for title, but Afraid of Being Witchy with a B. And this study looked at internal medicine residents, so not EM, right? And their experiences running a code or leading a resuscitation. And what they found, so first they asked the residents, what traits do you think make a good code leader? And probably not surprisingly for most of us, they found that they were stereotypically masculine traits. And then they asked the residents, like, how did you feel being put into that role? And the female learners had this increased stress of trying to balance the stereotypically masculine traits needed to keep this patient in front of them alive with the female traits that were required, and expected from them from the other people in the room. And so I recognized this when I was a trainee, and actually I watched one of my female residents do it flawlessly. She had a little bit of a Southern accent. She was from North Carolina. And I watched her run a code one day, and I pulled her aside and was like, what just happened? I have never heard your accent like that. She was like, oh, I do it on purpose because the nurses all think I'm being nice and I can tell them what to do and I don't have to say please and thank you and can you do this for me? And I was like, mind blown, smartest thing I've ever heard in my life. Right? So this study, Yes, I'm the Doctor, looked at surgery group and tried to address gender-based discrimination that they found. And so the group defined kind of difficulty being accepted as a leader, different expectations for male and female providers, and specifically the service work that female providers get asked to do, right? How many times are we asked, oh, can you just get me a urinal? Can you just get me a cup? Can I get a drink? I need a blanket, compared to our male colleagues. The assumption by patients that women are non-physician members of the team, and then the frustration with needing to repeatedly reaffirm that actually I am the doctor, and then sexual harassment. And so what this study found was that, first of all, females more often than males experienced gender-based discrimination, although 90% of their trainees, male and female, either experienced or witnessed gender-based discrimination. And the most common forms of gender-based discrimination that they recognized were receiving less trust from their patients, receiving less trust from other providers, and then an inappropriate verbal exchange specific to gender, right? And so what does this mean for us? Well, so you have a group of women trainees, right, that we know have high rates of imposter syndrome that we've already talked about, feel like they don't belong there. And then they have patients saying, I don't really trust what you're telling me. They have other doctors around them saying, I don't really trust what you're telling me. And then they're getting told, oh, you're too pretty to be a doctor, right? And that is not great for making a training environment for our trainees. Yeah. So where does this come from? Where does this environment stem from? Well, actually, it's mostly patients, patient families, and nursing, right? So it's not actually an environment that we are necessarily creating for our learners, and we have to recognize that. And why aren't our learners telling us this? Well, even though 90% of the trainees in this study reported experiencing or witnessing it, 4.5% reported anything. And the number 1 and 2 reasons were they felt like nothing was going to happen or they didn't know how to, right? So we can't expect that we are going to get told about these situations. We have to just assume that they are happening, and we have to try to find ways to support our trainees through it. And then sexual harassment, right? I think at this point, through the Me Too movement and everything else that we've seen in medicine, we accept that there is sexual harassment that occurs, and all of these different things can be forms of sexual harassment. We have a lot of studies now looking at medical students and sexual harassment. We have over 50% of medical students experience it. But again, the most common place that it's coming from is actually patients, families, and nursing. And that's really important for us to recognize. And so why overall is this conversation even important? Well, female physicians have higher rates of burnout already in medicine, right? And when we look at the female trainees that are studied, these episodes, shall we say, of gender-based discrimination impact burnout. They increase their burnout rates, right? It is more frustrating for me to have to walk into a room and repeatedly affirm that I actually can make decisions that take care of your medical care. how could that not contribute to burnout? So that's why we think this is an important conversation about our learners.
So now that we've established that there are differences in kind of the training that's experienced by our residents, our medical students, et cetera, I want to dive a little bit into gender and evaluations. So this first study, you may have seen it before. It's from the EM literature and it's been out about a few years. But basically what the authors of this study looked at were the differences in milestone attainment for male and female EM residents. And what they found was at the beginning of residency, both the male and female residents were getting about the same milestone attainment as decided by their faculty. But as they approached graduation, the females were getting graded or rated significantly lower than their male counterparts. So then the same authors took this data, which was like 1,300 evaluations, and looked at the words that were used. And what they found were that female residents were more likely to receive discordant feedback about their autonomy or assertiveness, and that their feedback focused more on their personality traits and not actually about their ability to practice medicine. So then this study here looked at gender bias in qualitative evals of surgery residents, and they found something similar. They found that across all PGY levels, right, male residents were being rated as better performing than their female counterparts, and it started an intern year, right? Even as soon as they began residency, unlike in our EM literature, as soon as they began, the male residents were consistently being rated higher by their faculty. And there was even a quote in this paper that said, "Female urology resident was a pleasure to deal with," right? These are the phrases that some of our female trainees are experiencing in the evals that they're getting back. So the past two studies, or three really, have been about faculty evaluations of trainees. And this here is looking actually at nursing evals of EM residents. And what they found in over 1,000 interactions between EM residents and nurses, the nurses rated the female residents as not as good as their male counterparts. They rated them lower in their ability to work as a team and also their actual clinical abilities. And when they looked at the words, again, more than 50% of the feedback to female residents were negative, when only 20% of the feedback to the male residents were negative. And I don't know why, but I think some of us in this room may speculate reasons, and I think part of it has to do with whether or not our female trainees are displaying those communal, those feminine, typically feminine traits on shift, and how the nurses are interpreting that and then providing their evaluations. So in EM, right, we're 30% women. So I asked myself, well, what does this look like in a specialty that's actually dominated by women? So we found this study looking at gender bias in nursing evals of OBGYN residents. And in this study, they looked at, I believe it was 2,000 evals, but 80% of them were from women, or of women rather, and 20% were of men. And they found the same thing. They found that the nurses were consistently evaluating the female OBGYN residents as less capable compared to their male residents counterparts, and once again, more negative comments. And in this case, it started again as soon as they started residency. The interns were actually hit the hardest across the PGY levels, where the female interns were consistently given negative feedback, lower evals, etc. And what's important about this is we're talking about evaluation, right? But the evals end up translating over into clinical practice. So this study looked at operative autonomy given to general surgery residents. And they looked at both the residents' perspective, like of their autonomy, and the faculty's perspective of how much autonomy was given to the residents. And what they found, for me, was unsurprising, but across all PGY levels, females were consistently given less autonomy than their male counterparts. It started at the beginning of residency, it carried through their chief year. And what was even more, I think, striking was they found that male residents were fast-tracked from the show and tell level up to the supervision only, much faster than their female counterparts.
So gender influences not only the evaluation of our trainees, but it actually has been found to influence the evaluations of our faculty as well, so those of us in the room potentially. So this study, Student Evaluation of Faculty Physicians, Gender Differences in Teaching Evaluations, looked at almost 15,000 evaluations of physician faculty across all different specialties. And they found that female physicians receive significantly lower mean evaluation scores than their male counterparts, and this was across all rotations. So when you look in the surgery rotation specifically, right, we see the largest disparity, which to me is not surprising. I think that's where maybe you have more agentic characteristics, you're acting less in your stereotypical gender role, right? But the second largest disparity was actually in peds, and I don't know where we could act more in our stereotypical gender role than taking care of children than peds, and we still see a huge disparity. So in evaluation of clinical faculty, gender and minority implications, they studied this again. There were about 10,000 evaluations that they looked at, and they found that there were significant effects based on gender and URM status on faculty evaluations. Female faculties in this study, they found were rated higher by female medical students, and male faculty were rated higher by male medical students. And then this one looked at the impact of gender on the evaluation as well as the clinical setting and specifically inpatient versus outpatient settings, right? And so overall, when they combined all of the settings, they found that in looking at like the 6 core competencies, males were ranked higher than females in 4 out of the 6. But when you took the inpatient settings specifically, males were ranked higher than women across all of them. And I think this is really important for us to recognize that we as female faculty may actually pay a bit of a gender tax on our evaluations, right? And those evaluations are important to us because we want to get promoted. And this actually can be a contributing factor to the leadership gap that we see in medicine.
So now that we've established gender bias seen in evaluations, we're going to talk a little bit about letters of recommendation. So this first study actually looked at medical student performance evals, aka the Dean's Letter, MSPE, for over 6,000 applicants to 16 different residency programs. So they're not even the same specialty, right? And what they found were that in those letters, the language that was used to describe our male and female medical students was different. And they found that females were more likely to be described as caring or compassionate or empathetic. And I'm not saying those are bad words. I'm just saying that they're different. They're different for our female versus male trainees. And if you're thinking about what kind of resident you want, different specialties might be looking for different things. Some might be looking for these words, but some might be looking for different words that apply more to their specialty. So this study looked at specifically surgery resident applications in their recommendation letters. And again, they found a difference in the language that was used. So the male medical students were more likely to be described with these things we call standout adjectives, and you can see them here: exceptional, star, bright, impressive, performance. And our female trainees, medical students, were more likely to be described with generally neutral positive terms like care, time, support, patience. And when I look at these, I do kind of think like this may look a little bit more like the communal traits that are expected of women versus agentic traits that may be expected of men. But remember, we're talking about a surgery residency program. And what are surgeons looking for? Are they looking for the person that's going to spend time in the room with the patient? Maybe. Or are they looking for the person that can perform and excel and has leadership skills? I don't know. And what I can't say is how this impacted anything like matching or rank list or whatever. But what we do know is that it's different. And because of that, I want to provide you with a couple other studies that validate the same thing, right? We're not just seeing this in surgery, but we're seeing it in ophthalmology, in radiology, in orthopedic surgery, and we're seeing it in EM. So this is a study that Dr. Parsons and I actually recently published looking at SLOs, which theoretically maybe are supposed to be a little less biased, right? They're letters of evaluation. And what we found here is that women and men, once again, are kind of graded differently. The way that their letters are written is different. And we specifically looked at the 7 EM qualification questions, which is like, are they committed to EM? How great are their differentials? Can they work as a team? Do they display a caring nature? And what we found were that women who didn't display a caring nature were hurt. It hurt the way that they were ranked and their overall global assessment. But if they did display a caring nature, it didn't help them. Whereas a man who was marked high for displaying a caring nature, their rank list position and their global assessment were increased, which I think keeps bringing us back to, like, what do we expect of our female trainees, and are we hurting them for not displaying the societal gender norms that we expect? So I want to give you a strategy. It's the time of year we're writing letters, whether it's for our residents applying for fellowship, for our medical students who are going into residency. And this is just one gender bias calculator. There are other options out there, but it's just a tool for you to use when you're writing your letters. Put them in here and just kind of see what the language looks like. Are you describing your male and female applicants similarly? Are you using different words? And maybe those words are the right words to use for them, and that's okay. But I think recognizing and acknowledging we all have our own bias and then evaluating it with a great tool like this may help us kind of ameliorate all the things that we're seeing across so many specialties. And I want to let you guys know, at the end of the talk, we will have a link with all of the resources of all the articles we have presented today.
So now we're going to talk about childbearing and parenthood in medical training. And first, we need to recognize that our female trainees may struggle to create the family that they want over the course of their career. So this is one of the first studies looking at infertility in female physicians, and it found that female physicians have a 24.1% rate of infertility across medical specialties compared to 12.1% national average. So we are double the rates of national average, meaning 1 in 4 of us females in this room may struggle with infertility. So this study is actually one I published a couple years ago looking at EM specifically, and we had almost 2,000 women in emergency medicine, including trainees, that answered the questions. And so we had a 24.9% of infertility in this study compared to the national average of 12.1. And I think actually one of the more pertinent things that came out of this, we were able to compare the age groups in our study to the national survey data. And so when we did that, we actually didn't find significant differences at some of the younger ages, but once you were 35 and over, we had huge rates of infertility in the female physicians compared to the national average, the national sample. So our residents, our trainees, they actually are at the best time biologically to create the family that they want, and if they do wait until after their training, they may have those increased rates, and so we need to find ways to support them through that. So when we extrapolated the data and only looked at female trainees that had had children during their training, we found that they had already delayed by about 2 years. So their age at first pregnancy on average was 28.2 years old compared to 26.3. And again, those are the trainees that tried to have children during residency, not all of the ones who are waiting until afterwards. So when we look at data outside of EM, right, pregnancy and motherhood during surgical training, they attempted to understand the resident experience of having children during their training, specifically their work schedule, maternity leave, breastfeeding, those sorts of things. They found that a majority of the residents took less than 6 weeks of leave and that they all felt like it was not enough time. They had 95% reported that breastfeeding was extremely important to them. 60% stopped early because they were unable to make it work with their work schedule. 40% considered leaving surgery because of the experience, and 20% said they would not recommend surgery as a career to other medical students. So that's surgery. Well, let's look at OBGYN, right? Because that literally is a career of people telling women having children what to do, right? And when they surveyed program directors in OB, they found that on average, program directors thought that they were offering their residents less time than their residents needed. 82% of program directors felt that their residents were negatively impacted, their education was negatively impacted by starting a family, and 50% felt that their residents' well-being was negatively impacted by starting a family during their training. And then this study, Maternity Leave and Residency, looked at both length of maternity leave and wellness outcomes for residents across all different specialties. They found the median length of leave was 7 weeks, with most people taking 6 and then some with 8 and 10. they found that greater than 6 weeks of maternity leave was associated with a statistically significant increase in breastfeeding. They also found that it was associated with greater support by the program, so the resident perceived more support coming from their program, greater satisfaction with their leave, and more likely to tell other people, that they would recommend having children during training. And then back to EM data. So this study was published a couple years ago on a return to work policy for new resident parents. And so they actually did for 4 weeks pre-due date for the childbearing mother, and then 6 weeks post-return to work for all parents, whether it was like adoptive, birth parent, or father figure. And they had no sick call, no night shifts, and no more than 3 shifts in a row unless the resident requested otherwise. And so that was kind of a very new topic for EM. But really, what do we do with this data? And I think, first of all, we have to actually recognize that this data exists and that our female trainees, like biologically, residency may be the best time for them to have children, and how do we support them in this? And that we have ACGME rules that we also have to deal with that aren't necessarily going to just allow for women to take a full 12 weeks without having any impact on their training. And so what can we do within those confines? And I think talking to our incoming residents day one of orientation and saying, hey, this is our policy here, to all of the residents, right? Not just your females, but to the males and the females, and saying, this is what our family leave looks like, here's what our policies are, so they don't have to ask you when they get pregnant, so they don't have to worry about whether or not they can do this, but make it a supportive environment for them. We should be offering this information to all applicants during interview season, right? And so one thing I try to do to anybody coming through our program is mention, like, hey, this is kind of what we do for leave. We've had, we've had this many people that have had children recently, something we're really supportive of. So nobody interviewing with us has to ask me that and guess that because I'm the woman with a child that's interviewing them, that I probably know it. And then we may need to be offering options to extend residency training for those females that want more than 6 weeks, with the understanding that, whether or not it's additional paid time, unpaid time, those sorts of things are going to be up to our institution, right? But most of us are going to hire somebody who took an extra 3 weeks or 4 weeks of residency because they had a child, as opposed to for academic difficulties, and I think those are two very disparate things. And then we have to consider how we adjust ACGME rules, because I think medicine was really made for men, and how now that 50% of medicine is women, how do we actually make it functional for us too?
Okay, so Dr. Parsons gave us some strategies around childbearing and parenthood, but I want to take a step back and think about all the things we learned today and what we're going to take home to our trainees to empower them, to encourage them, to make a difference when it comes to GBD in the clinical environment that we're working in. So we already looked at this study. Dr. Parsons kind of discussed it at the beginning, but what I wanted to talk to you about it is they built a really great roadmap that you can take home with you that kind of lays out strategies. If you're wanting to bring something home, right, bring it to your chair, bring it to your program director about what we can do from gender-based discrimination perspective. And one of my favorite things they found in this whole study, right, we established the issues that were experienced, and we established that a lot of it was coming from patients and patients' families, and also nursing. Well, what they did was they started providing everyone on the team with badges. And the badges made it very clear what your role was on the team. And it cost the department around $1,000, but that's not a ton of money, and it actually made a pretty big difference. Everybody had a badge. It said doctor or medical student or nurse practitioner or pharmacist or nurse or whatever their role was, and kind of helped offload some of that, I would say, kind of stress that is placed on our female physicians, whether trainees or not, to keep having to reiterate, no, I'm the doctor. Hi, I'm Dr. Mannix. I'm the doctor that's taking care of you. No, I'm not your nurse. I'm your doctor. I can get your nurse, right? The conversations that we have so often throughout our clinical days. And then this study also is giving us some take-home strategies. And what they did was they interviewed some attending physicians and asked them what they did to kind of balance the gender-based challenges they experienced in their own lives. And this was a quote that really kind of struck home to me. I think every woman in this role has been mistaken for a different caretaker role. So lots of requests for nursing help. I'm sure I've taken more patients off bedpans and brought more cups of water than maybe some of my male counterparts. And this is something I actually talk to my female trainees, more so my female medical students about. And there's nothing wrong with bringing someone a blanket or bringing someone a water or walking them to the bathroom. But if you spend your whole shift doing that, how many learning opportunities are you missing out on that your male colleagues are not, right? And I'm not saying like that it's their fault. I want us, as the educators, as the attendings in the room, as the senior residents, to see those moments and find ways that we can help empower our learners, right? Say, when the patient asks for that, be like, this is actually student Dr. Parsons. She's on rounds right now, but I'm happy to get your nurse Billy to take care of that for you, or whomever, right? And just reiterate the role of the person that they're asking, and also kind of offload that stress from the trainee, because the trainee has a really hard time saying no, right? That is like next to impossible. But if we take that away from them and make it so they don't have to say no, maybe they can engage more in the clinical environment and not miss out on learning opportunities. So a couple other things that were discussed in this paper was making sure that they kind of displayed themselves as a physician. And they talked about strategies they've used, and one of them was wearing a white coat. And I don't know about you, but I don't really wear a white coat. Like, EM is just not always a white coat kind of vibe place. But there are other things you can do, whether it's embroider your doctor name on your scrubs or the jacket that you wear, get one of those badges, right, for yourself and maybe the other people on your team to help clarify the roles. You also see here, all of the women on this slide are using the phrase, I'm the doctor, right, reiterating their own role. But also take that opportunity as the team lead to reiterate the roles of everybody else in your group, whoever they may be. This is the senior resident, right, or the most senior doctor, right, in training, or however you want to phrase it, because sometimes patients may not understand the medical hierarchy. I don't blame them, it's confusing, right? And establish who is your nurse versus who is your student doctor, which is another strategy I want to give you all to take home is, instead of using the phrase medical student, I encourage my trainees to use the phrase student doctor for two reasons. One, once you graduate, you just drop the student, and Dr. Mannix is something I've now been saying for a while. I've been saying student Dr. Mannix, now I'm Dr. Mannix, and it helps that transition, because that moment was hard for me to kind of fully embrace that role. And it also removes a little bit of the confusion. Oh, you're in medical school. In medical school for what? And whether our patients don't know that medical school is to become a physician, sometimes our family friends don't, or the people we meet out in the community, right? So I like the idea of changing the phrasing to student doctor, and I try to empower my medical students to use it. And similarly, I like to empower everybody to use the phrase doctor and their last name whenever they walk into a room with a patient. And I know there are regional differences, and that may not be what it's like in your community, but the reason I do that is because one of my male residents can walk into a room and say, hey, I'm Brad. What brings you in today? And he is assumed to be the doctor. No question, he uses his first name, but he's tall and he's in scrubs, and of course he's the doctor. Whereas I walk in the room and say, I'm Dr. Mannix, I'm the supervising doctor that's taking care of you today, right? And I come back and I'm still not the doctor, and I correct it, and I come back, and the reason I bring this up is because I think our male colleagues, and maybe even some of us, have a little bit of a privilege to be accepted as a physician without having to use all this language. So I ask you to kind of evaluate your privilege, evaluate your institution, but maybe consider encouraging everybody in your department to use their doctor name when they're talking to patients.
All right, so we went through these things today. We talked about the impact of gender on our trainees, the influence of gender on patient care, evaluations, and the expectations. We looked at gender on faculty evaluations, bias in letters of rec. We talked about childbearing and parenthood in medical training, and we hope that we provided actionable strategies to reduce gender-based discrimination in your institutions. This is our QR code for all of the resources that we talked about today, and I will leave it up there.
Yeah. There's also a link on the bottom. If for some reason the QR code isn't working for you, you can type that in. While we're here, while we have this up, we're happy to answer any questions. I'm going to pull up the doc and see if anyone threw anything in it.
I have it. It's
empty. Cool.
anything.
I'll just make a random comment that we have badges, and I think like between mine says either MD or doctor. The MD drives me crazy because a lot of people don't even know that that's the letters after your name when you're a physician. And then like the residents just say resident.
Right.
Patients don't always know like what a resident is, what the difference is between them and me. So we have the badges were a good thought. They've just not exactly gone about it the right way, and so they've not been terribly helpful in preventing
We have ones that say physician for us and resident for the residents, and it's small. And I have watched. We go to codes at our institution, so when I walk into a code, nobody actually thinks I'm in charge unless they recognize me from being there for a while. But I have seen other people trying to scan my badge, and it's always like flipped the wrong way where it doesn't actually say what they need, and they're trying to figure out, am I actually in charge? And so I got one of these doctor badges for underneath because I've been trialing it because we're trying to bring it to the entire institution from our Women in Medicine and Science group. And it definitely needs to be a push for the entire hospital, because what I have noticed is everybody who knows me, all of my nurses and techs are like, why do you have that? That's the most ridiculous thing on the planet. And I'm like, y'all know that. Like, you know who I am. But when I go, the patients don't understand this. When I go upstairs, other doctors don't know who I am. And having that label, and I agree, one thing I said, it can't be MDDO, and it can't say physician, because honestly, and you know where I work, but we work at a place where our patients' medical literacy is so low that physician isn't necessarily something they understand. And that's kind of the same thing that we're getting at with medical student versus student doctor, right? I cannot tell you how many times I said, I'm a medical student. They said, oh, you're going to be a nurse. And I'm like, well, no, you go to medical school to be a doctor, but that isn't implied in the name. And so that's where like our student doctor comes in, and we have to be very clear with the terms we're using. And so we pushed for those exact doctor badges in orange at our institution. So we'll see if that happens. Yes.
Hey, Melissa. So, I'm at Bay State. This is obviously a topic that I'm very, very passionate about. Thank you for providing such a great talk and such great resources and up-to-date resources. There's so much coming out about this stuff. I just wanted to share another resource which I thought was really, really helpful. And there's a book out there called New Rules for Women by Ann Linswin, Litwin. And what she did is she was an organizational psychologist in her PhD, and she went to women in all these different industries, and she said, hey, what's the deal? What is it so challenging about working with other women? And she came up with this idea of friendship groups. And why I bring this up is because we spend a lot of time in gender equity literature. How do women have equal footing at the table with men? We spend far less time as to how do women become leaders of other women. And it's a really, really delicate, challenging thing, and it's very hard to articulate because it's hard to know what that vague, you know it's there, it's hard to label it. And her work is the stuff that I have found to be most helpful. In what she did, and all this qualitative literature, she said, look, when we're young girls, we came up with this idea of the friendship rules. And the friendship rules is you're incredibly loyal, you're incredibly equal, you listen, and you share secrets. And then the fifth thing is you never talk about the friendship rules. So any of us who had a teenage daughter has seen sometimes these really intense relationships just stop. And you say, you're not hanging out with the name in. And they're like, yeah, we got to fight. And I would say, well, what happened? And you'll hear something, and you're like, well, did you talk about so-and-so with us? Did you sit down and talk? She knew what she did. So there's this huge void because we're taught to indirectly, me to tell you something, and you're going to tell him something, and you're going to tell, and maybe it'll get back to Melissa. And you can't do that in medicine. So if we look at
Thank you so much. I added that to the question. If anybody opened the question sheet, I added the name of the book. That will be on my reading list to go through. But I think it's a great point with, looking at our resident nursing evals and even our faculty nursing evals and those sorts of things, and recognizing that some of that is probably playing in, and how do we direct our trainees to work through that well. And we've actually had a lot of conversations in our meta group recently about, do I really want more nursing evals of my residents if it's a biased thing that is going to not actually help my female residents at all, and it's been interesting. And actually, I don't know if any of you were in the plenary abstracts this morning. L.A. Alvarez presented the same study we presented on gender, but he presented the race study. So we did both gender and URM status. And one of the questions asked was like, how do we get nursing evals to look at this? And I was like, well, we don't. Luckily, I did not raise my hand and reply. I was like, I don't know that you do, because I think we're going to see the same biases. So, yes, ma'am.
I see it too when we use standardized patients. We had a simulation where we had, it was a female standardized patient. And it was very obvious that the female resident was spot on, hit all the critical points and stuff. But then when we saw the evaluation that standardized patient had of both the resident males and females, the male resident evaluation was way higher. We looked at each other, my colleague and I, and went, what just happened here? It was so obvious to us that she was 100 times better, in terms of differential, ordering the right medications and, everything, including communication. We thought that she was very clear, stated everything, and it was mind-boggling to us when it didn't happen. And so it even comes around that, especially in this day and age where they really promote 360 degree evaluation.
Yeah, as we're looking at patient data, right? Like patients giving us evaluations of faculty and patient satisfaction scores and things like that. This really impacts us. And actually, I should use the mic because they said we're recording it. But one of the stories I always tell my residents is when I was working in the community, I had my spiel down. I would go in, introduce myself. I'm Dr. Parsons. I'm going to be the doctor taking care of you today. And I would go in with my nurse so I could also introduce my nurse. And it was very clear who was who. And one of my patient evals was, I never saw the doctor while I was there, but my nurse was extremely knowledgeable, blah, blah, blah. And I was like, yes, probably because it was me. And it's just like, if we're going to RVU-based, but also like patient satisfaction scores as part of our bonusing and pay structure, like this is actually detrimental to women. And we really are going to have to
the
talk
promotion,
through that.
leadership gap, the pay gap, a lot of it's going to tie back to this, right? We talked about the evals, we've talked about nursing evals, patient evals, et cetera. I think it's going to continue to impact us.
That would be a really interesting study, though, looking at
the SIM.
Yeah, using SIM to study kind of the grades that patients give people. That's a really cool idea.
Yeah.
Yeah.
I was just going to share that, one thing that we did as a group of residents when I was in training is that we do these like end of the year sketches at our like resident retreat, and all of the female residents in my group had like kind of just pooled all of our faculty evaluations for the fourth year, and it was like a mean tweets sort of thing where we just like read all of the stuff, and we both got like every end of the spectrum, like that so and so is not served enough, so and so is like too overconfident, and we've all read the same things about each other. They're just everyone was all doing that. I think it was really bonding and helpful to know that you're not in it. I feel like just sharing that with each other, that like we're all getting these crazy biased comments.
It's not a me problem, it's a we problem. Yeah.
That's what we tell our residents. So we have a resident group, and that's one of the things we go through is like evaluations, and you're gonna see this. It's okay. Like we know that this is like, come to one of us and talk about it when you need to. Go to each other and talk about it, because it is very much a we problem. But until we address that as a we problem, we all internalize it as this is me, this is my problem. And like as a resident, I was telling them earlier, I called one of my seniors and would cry about my evals, and then she would read me hers, and she's the best doctor I've ever seen, and they were terrible, and I was like, oh, it makes me feel so much better. Okay, great, I can keep going in life, right? But like this shouldn't be the experience that we have, and how do we adjust that? And I think as a group, because we do this work, the guys in our med ed group have gotten much better about being able to have conversations where we call them out. Not necessarily we call them out, but we all call each other out about biases and like, well, are you saying that about her because she's, you know, voicing her opinion more, saying this is what I want to do, and is being assertive, and now we're saying that's not good, you know, and being able to kind of challenge those gendered expectations, I think, are really important in our CCC meetings and things like that. Yes.
Could I just add one more comment? So, I study sex and gender, and I do a podcast called Sex and Why, and I had a chance to interview Dan O'Connell and Anna Mueller. And they're the ones that did the first one where they got the milestone data and said, oh, by the way, there's a huge difference between the first year and the third year. So the study was female physicians, basically by the time they were third years, they got less milestone competency across all 23, but they didn't start out that way. But they talked about how they did that study. So Arjul and Dan developed a proprietary product that they actually developed to do online milestone evaluations because they were scribes trying to get into med school, and they noticed that the attendees were having a lot of problems going on after the shift to do all their, they're like, what if we develop this? So they developed this and they tried it out in all these residencies, and one day they were just looking at their data, and they weren't invested. They're looking at their data as these scribes, and they were like, oh my God, look at this. And they weren't associated with anybody. So somehow they got into a development program at the University of Chicago to further develop this app, and then they found a medical sociologist, which I didn't even know that. I didn't even know that title
Yeah.
existed. And they helped them, like she's reading it, and she's going, oh my God, how did you get this data? And realize what an incredible data trough it was, and help them publish it.
Yeah. I listen, the podcast is great, highly recommend listening to it. That has helped us. So we give a version of this talk for GMD to medical students across the country, but with different literature, but same type of thing. And that it's one of the things that we talked to all of them about, and a lot of it was stuff that I pulled from your podcast, so thank you. But yeah, I love like the explanation and hearing how they did that was amazing to me. And when you look at it, like if you really think about why as third years do we see, like why as women progress through do we see the gap, it's because they go from saying I don't know what I'm doing, I'm going to follow and do what I'm told, to saying, hey, attending, this is what I want to do and this is how I'm going to do it, and we're punished for that, and our male colleagues are patted on the back for that. And that's where a lot of times we step in as the women in our med ed group and say, whoa, hold on. Like if I did that, nobody would have a problem with it now because now I'm an attending and you expect that from me. But like we should expect this from our third year trainees. We expect it from McKenna. Thank you for being my man in the room. Right, but we expect this from McKenna. Why do you not expect it of me? We were the same year training together. I don't know you, so I'm not going to call you out. And I know you're a med student, so I'm certainly not going to call you out. But he trained with me, so I can call him out all I want.
It's funny though, so I feel like we were saying about the milestone study was that they just saw it in the data. It's kind of like what you saw in your moment, right? And that's how I feel like a lot of these studies may come to be. That's why we did the SLOW study. It's taken us 3 years. We have 3 publications from it, but I was reading SLOWs and I'm like, something's not right. And then I conned 12 people into reviewing 5,000 SLOWs, and 3 years later, here we are. But sometimes, it's the things you notice, and then you start digging, and you start finding out that, like, it's not a me problem, it's a we problem. Like, this is actually in the data if we just look for it, so. We probably have time for one more question, and then we gotta let everybody go. But thank you all so much for being here.
Conversation, it's great.
Yeah.
Having a small